Madam, we are live now.
Yes. Madam, we are live now.
Yes.
So good evening, doctors. I, Shuman, on behalf of Shield Healthcare, welcoming you all in today's another interesting topic on recurrent pregnancy loss, and our guest speaker is Dr. Arti Shukla, madam. Before moving into the webinar, let's have a look on our knowledge sharing platform on which we regularly conduct this medical session. This is our Shield Connect page. It's a blog section. Here you can find all the related articles in recent times in this portal, and these are the past webinars. Already we have conducted many webinars in many interesting topic by different practitioners across India, and here you can find our key opinion leaders. Presently more than 500 doctors are currently supporting us this knowledge sharing initiative of Shield Healthcare. And here is another awareness segment is there. You can find many things like PCOS awareness, menopause, GDM awareness, immune booster, COVID-19 and thyroid awareness. In each and every section, you will find all the related information on that. So now it's time to start the session with Madam, and it's my honor to introduce Madam. Madam is the ex-president of BOGS. Madam completed MBBS, MD Obstetrics and Gynae from RMCH Ranchi, and Madam is the organizing secretary of Combined Bihar and Jharkhand Annual Conference. So with this short introduction, I request Madam to take over the session, and meanwhile I request all the participants for your active participation, and please post your queries on the QA dashboard of the Shield Connect page. So once the talk will be over, we shall have a short discussion on this topic with Madam. So thank you, Madam, and over to you, ma'am.
Good evening, everyone. We are going to start our session on repeated pregnancy loss. Please put the slides on. Yes. The loss of pregnancy. Next slide. Next one. The loss of pregnancy at any stage can be a devastating experience, and particular sensitivity is required in assessing.
Madam, Shobha Sinha, Madam, Varuna Verma, Madam, kindly mute yourself. Sorry for the interruption. Kindly mute yourself. Shobha Sinha, Madam, kindly mute yourself.
So we are going to start our topic on recurrent pregnancy loss, which we come across in our practice many a times. The loss of pregnancy at any stage can be a devastating experience, and particular sensitivity is required in assessing and counseling couples with recurrent miscarriage. This is emotionally traumatic, similar to stillbirth or neonatal death. Next. RPL is classically defined as 3 or more consecutive losses at less than 20 weeks of gestation or with a fetal weight of less than 500 grams. Ectopic, molar, and biochemical pregnancies are not included. Next. Next. Yes. 60% of the embryos never yield a live birth. 30% of the implanting embryos miscarry often before the woman realizes she is pregnant. 15 to 20% of clinically detectable pregnancies abort. 5% women have recurrent miscarriage in more than 2. And 1% women have recurrent miscarriage more than 3. Next. When you lose a baby, but you are made to feel like it's just a common medical condition, it's heart-shattering. Next. We should start investigating the repeated RPL after second abortion. Next. The causes are the biggest dilemma. The causes can be infective, like tuberculosis. It can be genetic. It can be endocrinal, it can be environmental, it can be alloimmunity, can be thrombophilia, can be autoimmune, and can be uterine or anatomical causes. Next. There are different risk factors like gestation age at the time of abortion, age of the patient, both husband and wife, and the history of previous important. These three factors should be considered in each and every case. Next. The age at which the abortion occurs guides us to the underlying cause to some extent. 4 to 6 weeks of abortion may be due to alloimmunity or luteal phase defect. 5 to 7 weeks pregnancy abortion can be due to genetic causes. 8 to 10 weeks can be due to immunological causes. Mid-trimester is mostly due to anatomical causes or APLA. Next. Advanced paternal age accounts for 2 to 5% of RPL. Karyotyping of both partners is advised. Advanced maternal age increases the risk of chromosomal abnormality like trisomy 13, 18, 21, 47 XXY or 47 XXX. Advanced paternal age, there is increased risk of autosomal dominant sex-linked recessive diseases. It is seen that the balanced translocations are more common structural abnormality and results in several abnormality, genetic abnormality in the fetus. Next. If the woman have one live-born infant, it is a good prognosis. With no prior fetal losses, the recurrence rate is 12% for the next pregnancy. With at least one prior fetal loss, the recurrence rate is 24% for the next pregnancy. With 2 prior fetal losses, recurrence rate is 26% for the next pregnancy. With 3 prior fetal losses, recurrence rate is 32% for the next pregnancy. A woman who have not had at least one live-born infant with 2 or more fetal losses, the recurrence rate for the next pregnancy is 40 to 45%. Next. At the time of miscarriage, second or third time, we should document the pattern and the trimester of the pregnancy loss, whether a live embryo was present or dead fetus was there, or clinical and ultrasound findings should be noted. We should carefully document any suspected uterine abnormality at surgical evacuation and send the product of conception for histopathological examinations, for tuberculosis examination, and for karyotyping. Next. How to evaluate patients of RPL? Family history should be taken of the recurrent miscarriage, PCOD, diabetes, genetic disorder, thrombophilia, early onset cardiovascular diseases, or history of stroke in a less than 50 years of age. Physical examination to identify signs of endocrine or gynec diseases. Opportunistic screening for BP, pap smear, and rubella IgG should be done. Next. In cases of RPL, detailed history to clarify and document RPL should be done. Recurrent spontaneous abortion, whether it is recurrent spontaneous abortion or a chemical pregnancy loss or early pregnancy loss before 8 weeks or after 8 weeks, second trimester abortion or stillbirth. Next. Past obstetrical history is also very important, whether there is full-term birth or premature birth or malformed fetus. Term of pregnancy at the time of abortion, location of the fetal heart or anembryonic pregnancy. History of the environmental factors should be taken, like smoking, exposure to anesthetic gases, toxins, and chemicals. And the lifestyle high-risk factors are obesity, daily caffeine intake more than 300 milligram, alcohol consumption, and use of NSAIDs. Next. Now the uterine factors. This can be acquired or congenital. Congenital anomalies, 10 to 15% of women with RPL have congenital anomalies versus 7% in all women. The abnormal implantation due to decreased vascularity if it is implanted on the septum, or increased inflammation if it is implanted on a fibroid, and there is decreased sensitivity to steroid hormones. Next. This we will discuss afterwards. Next. Now the acquired defects like leiomyoma. Of this, the submucous is of the importance only. The mechanism of abortion in submucous is due to their position, due to poor endometrial receptibility, and due to degeneration with increasing cytokine production. Next. Other uterine causes are uterine polyp and intrauterine adhesions, that is Asherman syndrome. It is caused by excessive curettage for pregnancy complication. It traumatizes the basal layer during DNC and causes formation of granulation tissue. So there is insufficient endometrium to support the fetoplacental growth. There is menstrual irregularities, hypomenorrhea, oligomenorrhea, cyclical menstrual pain, and infertility. Next. Other uterine causes are cervical insufficiency, which causes recurrent mid-trimester abortion. And the other one is exposure of DES in utero, causes T-shaped uterus or cervical changes. Next. Now the uterine assessment of the uterus, how it should be done? By the sonohysterography. This is more accurate than hysterosalpingography and differentiates septate from the bicornuate uterus. Hysterosalpingography does not evaluate outer contour and is not ideal for the cavity. Hysteroscopy is the gold standard for the diagnosis and treatment of intrauterine lesions. Next. Uterine assessment should be done with the ultrasound also for the presence and location of the uterine myomas or associated renal abnormalities. MRI to differentiate the septate from the bicornuate uterus. Hysteroscopy, laparoscopy, or MRI are the second line test when additional information is required. Next. By transvaginal sonography, we can diagnose tuberculosis, uterine malformations, evaluate uterus and cervix, evaluate the ovaries and endometrium, evaluate the corpus luteum, and evaluate the pregnancy. Next. In tuberculosis, the endometrium is persistently thin. Next, it is bright and echogenic. It is hardly 2 to 3 millimeters. Next. Next. Now the uterine artery Doppler, the changes for pregnancy is almost zero. The chance for pregnancy is almost zero if the PI is more than 3.019 on the day of HCG administration. Patients who get pregnant have a lower RI, 0.53 versus 0.64. Next. Now the developmental or congenital malformations of the Mullerian duct may also causes adverse pregnancy effect. These anomalies include, first, the septate uterus. It is most common and the poorest outcome is there in septate uterus. Miscarriage is more than 60%. Fetal survival with untreated cases can be 6 to 28%. The mechanism of abortion is not very clearly understood, maybe due to poor blood supply or poor implantation. This is most common anomaly, that is 55%, may be incomplete or complete. 25% causes early abortion and 5 to 7% late abortion or premature labor. Next. The septal defects can be diagnosed by ultrasonography, hystosalpingography or histoscopy. Correctable by the histoscopy or by the metroplasty. Next. Bicornuate uterus. This accounts for the 10% of the anomalies. There is incomplete fusion of the uterine horns at the level of fundus. Two separate but communicating endometrial cavities are there. Abortion rate is 30%. Premature labor is 20%. Successful pregnancy are well known. Next. Unicornuate uterus accounts for 20% of the anomalies. Agenesis or hypoplasia of one Mullerian duct. This may be alone or accompanied by a rudimentary horn which may have a cavity or not, or which may be communicating or not communicating. These are associated with the renal anomalies. Successful pregnancies are well known. Next. Uterus diadelphus is least common, 5 to 7%. Abortion rate is 43% and premature birth is 38%. Next. Next. Do fibroids causes recurrent pregnancy loss? As we have already talked, the submucous variety can cause the recurrent pregnancy loss. Next slide. Intramural or subserous will not interfere. Submucous fibroids may be associated with RPL and should be removed hysteroscopically. Intramural and subserous do not require removal. Next. Now the treatment. Treatment of the these congenital anomalies are mainly surgery. Hysteroscopy is the main treatment. That is the procedure of choice. Septum excision is done by hysteroscopy and polypectomy can be done. Laparoscopic myomectomy for fibroids and laparotomy may be needed sometime. Next. Now the cervical incompetence. Cervical circlage is associated with potential hazards related to the surgery. The risk of stimulating uterine contractions and hence should only be considered in women who are likely to benefit. Transabdominal cerclage has been advocated as a treatment for the second trimester miscarriage and prevention of early preterm labor in selected women with previous failed transvaginal cerclage and or a very short and scarred cervix. Next. Women with a history of second trimester miscarriage and suspected cervical weakness who have not undergone a history indicated cerclage may be offered serial cervical sonographic surveillance. Next. Now the immunological factors. This can be autoimmune or alloimmune. Autoimmune is directed to self and alloimmune is directed to foreign tissue. Autoimmune includes SLE and antiphospholipid syndrome. It has been appreciated that pregnancy wastage is increased in women with SLE. Subsequently, many women with SLE were seen to be having antiphospholipid antibodies. Clinical and laboratory criteria for the diagnosis of APLS are, clinical criteria are one or more unexplained death of a morphologically normal fetus at or beyond 10 weeks, or severe preeclampsia or placental insufficiency necessitating delivery before 34 weeks, or 3 or more unexplained consecutive spontaneous abortion before 10 weeks. These are the criteria which indicates towards APLS. Lab criteria are presence of lupus anticoagulants, medium or high serum level of IgG, IgM anticardiolipin antibodies, or anti-beta-2 glycoprotein IgG and IgM antibodies. Now the alloimmunity and abnormal maternal immune response to fetal or placental antigen. The immune tolerance of mother to a semi-allogenic fetus remains incompletely understood. An attractive theory suggests that normal pregnancy requires the expression of blocking factors that prevent maternal rejection of paternally derived foreign fetal antigen. Next, autoimmune systemic lupus erythematosus risk for the loss is 20%, mostly in second and third trimester of pregnancy, and associated with antiphospholipid antibodies. Antiphospholipid syndrome, APA. 5 to 15% of women with repeated pregnancy loss may have APA. APA likely induce microthrombi at placental site. Altered vascularity affects developing embryo and induces abortion. Next. APLS antibodies are heterogeneous group of antibodies directed against phospholipids and or phospholipid binding protein. The commonest detected APLS are anticardiolipin or lupus anticoagulants. Next. The mechanism responsible for thrombosis and fetal loss are uncertain. One is APL binding with the phospholipids may interfere with coagulation cascade, or NXCV is decreased with APL, causes placental thrombosis and infarction. Next. APL also affects thromboplast differentiation, proliferation, and invasion. So there is impaired implantation. In this case, there is role of immunoglobulins to some extent. Next. Now, alloimmunity is diagnosed by HLA cross-matching, husband's lymphocytes and wife's serum. Treatment is transfusion of the husband's lymphocytes, pure suspension of husband lymphocytes, that is 3 ml of blood is made to 10 ml of suspension, and inject 5 ml IV, 1 ml subcutaneous and 1 ml intradermal. But nowadays this is not practiced. Next. Immunological factors treatment, immunostimulating therapies, that is leukocyte immunization, and immunosuppressive therapies. Next. We will come to this last, next. Now the endocrine factors. Mild endocrine diseases are likely not cause for the recurrent abortion. Thyroid diseases which are poorly controlled, hypo or hyperthyroidism, may cause infertility and pregnancy loss. With there is increased thyroid antibodies in some cases, even if the patient is euthyroid. There is no strong evidence that it will cause repeated pregnancy loss. Next. Now the PCOD itself will not cause RPL. The pathological physiological changes which occur in the PCOD can cause sporadic loss like hyperinsulinemia, hyperandrogenemia, and hyperglycemia. And this can be, metformin is the treatment to reduce and eliminate the risk of miscarriage in PCOS women. Next. Now the luteal phase defect. Progesterone is essential for implantation and maintenance of pregnancy. A defect in the corpus luteum causes impaired progesterone production. However, LPD cannot be diagnosed during pregnancy. A consistently short luteal phase duration is the most reliable diagnostic criteria. Next. Now we will talk about the progesterone at this time. The progesterone, how it acts, it inhibits Th1 immunity and shifts from Th1 to Th type 2 response. Progesterone can be given in luteal phase defect by orally, intramuscularly, or intravaginally. Intravaginally, it may increase the local or intrauterine concentration, or it will also avert any adverse systemic side effect. Now, hyperprolactinemia. There is insufficient evidence to assess the effect of hyperprolactinemia as a risk factor for RPL. Next. Next. So what are the endocrinal tests we will do? We will do thyroid function test, 3T4 TSH. We will do serum prolactin, glucose tolerance test, HbA1c, serum FSH, serum LH, progesterone.
आपका क्लास चल रहा है.
Excuse me, Shweta Shankar madam, kindly mute yourself.
Next slide, please. The treatment is of the luteal phase insufficiency is with progesterone, which we have already talked, and we can also give human chorionic gonadotrophin in these cases. Next. Next slide. In PCOS, insulin sensitizing agents like metformin. In overt diabetes mellitus, pre-pregnancy glycemic control is achieved. In hypothyroidism, thyroid hormone replacement is done. Next. Now, thrombophilia. Thrombophilic factors predisposing to thromboembolic events are associated with both sporadic miscarriage or repeated pregnancy loss. This can be hereditary or acquired. It is suggested that the association is caused by an increased risk of thrombus formation at the placental blood vessels, resulting in placental infarction. Thrombosis on the maternal side of placenta will cause impaired placental perfusion, will cause late fetal loss, IUGR, abruption, or PIH. Relationship with early loss is less clear. These thrombophilia can have hereditary factors like deficiency of antithrombin, protein C, protein S, carriage of factor V laden or factor 11 gene mutation. Acquired can be antiphospholipid antibodies, anticardiolipin antibodies. Hyperhomocystinemia can be both acquired or hereditary. Next. This we have already talked, inherited thrombophilic defects. Next. Now the antithrombotic therapy. The combined dose of low dose aspirin and subcutaneous heparin is the treatment. Next. Now the miscellaneous factors like emotional or chemical stress. These can cause sporadic loss, but not repeated pregnancy loss, like exposure to anesthetic gases, nitrous oxide, formaldehyde, pesticides, lead, and mercury. No association with RPL is proved. Obesity, smoking, and alcohol and caffeine are associated. Association with RPL is unclear, and exercise does not increase sporadic or RPL. Next. Now the infections like Listeria, Toxoplasma, CMV, and primary genital herpes can cause sporadic loss, but not RPL. Male factor, only one thing is important: advanced paternal age may be a risk factor for miscarriage. Next one, next slide. Now the decreased ovarian reserve will cause the decreased quality and quantity of oocyte formation, and women with unexplained RPL may have higher FSH and E2 than the woman with known case. Next. Now, this is actually a take-home message. It is very small. Can we enlarge the things? Actually, this is the summary of the current guidelines from Royal College of Obstetricians and Gynecologists, American Society for Reproductive Medicine, and European Society for Human Reproduction, and embryology compared with the new proposed algorithm for the evaluation of recurrent pregnancy loss. So we will go to the new proposed mainly. The first thing is parental karyotyping. The new proposed algorithm for 2020 is not recommended unless product of conception CMA reveals unbalanced translocation. CMA is chorionic microassay. When product of conception are tested by the CMA, if it reveals unbalanced translocation, then only parental karyotyping is needed. Now the POC cytogenic analysis. It is recommended only use CMA for the second and the subsequent pregnancy loss. Now the uterine anatomy evaluation is recommended by the 3D ultrasound. Antiphospholipid antibodies recommended: lupus, anticoagulants, anticardiolipin antibodies, antiphospholipid serine antibodies should be tested. Now the thyroid function, it is recommended TSH and TPO when TSH is more than 2.5. Prolactin testing is recommended. HbA1c is recommended. Hereditary thrombophilia only recommended if a personal or the strong family history of thrombosis or thrombophilia. Sperm DNA fragmentation is not recommended. PCOS and insulin resistance not recommended. Luteal insufficiency not recommended. Ovarian reserve testing not recommended. Use only for explanatory purpose. Vitamin, the main important thing is, which we are not doing, is vitamin D supplement. Recommend to supplement vitamin D. It should be supplemented. This is the new algorithm for the investigation of the repeated pregnancy loss. Now the next slide. This is the proposed evaluation for the recurrent pregnancy loss. After second trimester, for first trimester loss, the workup include screen for the weight extremes, alcohol and smoking, cavity check by the 3D ultrasound, that is ultrasound mapping should be done, screen for APS like lupus, antiphospholipids and anticardiolipin antibodies, endocrine testing, TSH, TPO, prolactin and HbA1c. Manage the abnormalities 1, 2, 3, 4 accordingly. Consider prophylactic, always it is said that consider prophylactic vitamin D supplementation to all. Provide psychological support, which is very important. Now, the POC CMA cytogenic analysis should be done. That is after second miscarriage. Now, if the POC is aneuploid, no further testing is needed. If the POC is eploid, then if the abnormal cavity, endometrial etiology or APS should be addressed. If no definite etiology is found, then it will go to the unexplained cases. Now, if the POC shows unbalanced translocation or inversion, do parental karyotyping, genetic counseling, consider IVF or expectant management. In unexplained cases, complete full workout versus expectant management. Consider in unexplained cases, consider hereditary thrombophilia testing, consider sperm DNA fragmentation testing, consider parental karyotyping, consider luteal phase deficiency testing, consider chronic endometrial testing, consider hysteroscopy, and address the identified etiologies. After third miscarriage, all the things which we are doing is after second miscarriage. After third miscarriage, if no testing has been done so far, investigate and manage according to the above algorithm. If the above algorithm has been followed in the previous miscarriage, repeat POC chromosomal testing and complete the full workout if not already done. If all possible known etiologies has been addressed and POC aneuploidy is repetitive, consider expectant management versus IVF by PGT is the pre-implantation genetic testing should be done. This is all the summary. Next. So the conclusion is that as many times we do not know the cause, we have seen that low dose aspirin, subcutaneous heparin, folic acid, progesterone, sulcoseril, that is increased oxygen supply, or tocolytic drugs will often surprisingly give benefit and good outcome. Thank you very much. That's all.
Thank you very much, madam, for this nice presentation. Just give me 1 minute time, ma'am, to check whether any question is there. Madam, first question, ma'am, how means thyroid hormone means necessary to check this thyroid hormone in case of this RPL? What is your thought of?
It's very important to test thyroid and thyroid hormones, and it's for normal population it can be normal range is up to 5, but for pregnancy it should be less than 2.5. Otherwise it affects the baby in many ways. So thyroid hormone is very necessary, and we should start and we should over-treat also as soon as it is diagnosed. So in the first visit, we should do the thyroid testing.
Thank you very much, madam. Madam, another question is, if a patient is rubella IgG positive in case of this RPL, so what can be the treatment approach for that particular patient?
In the rubella IgG positive patients, we ask them to avoid pregnancy for the next 6 months, and we give vaccination for that. And after, we have to tell them that not to conceive for at least 6 months after giving the injection. And we should repeat the rubella IgG test after 1 or 2 months.
Thank you very much, madam. And ma'am, what is the dose titration in this antiphospholipid syndrome, means antibody syndrome?
What?
In case of antiphospholipid antibody syndrome, ma'am, what is the dose titration? Means how to tackle that one also?
If the antiphospholipid syndromes are increased, the line of treatment, it causes coagulation. So we give anticoagulants to treat this. One is the ecosprin and another is the heparin injection. or now we are giving what's called subcutaneous injection of what's the name of that? I am forgetting.
Anyway, madam, that anticoagulant has to be given. What we
instead of
yes.
heparin, now fragmented, this new thing has come, which helps a lot. We give subcutaneously daily or alternate day to increase the blood supply to the embryo, and this helps to prevent the coagulation, which is caused by the antiphospholipid antibodies.
Madam. And ma'am, another thing, ma'am,
enoxaparin injection, 40 international unit.
Okay, sure. Ma'am, the last question is, as sperm parameters is also very much important, and that also can cause this RPL. But in case of what we see in that recent recommendation suggests that there is no need to check the sperm DNA fragmentation, which is also a very much important parameters. Although if you find some patient that motility morphology
but it is not recommended to test in all the patients. Only when there is unbalanced translocation in the product of conception, then only we need to do the sperm fragmentation testing.
Okay. So thank you very much, madam. I could not find any other question. Am I audible, madam? Am I audible, madam?
Yes, audible, Suman. Maybe ma'am having some network issue.
Okay. So let madam join. Sorry, maybe some network issue, doctor disconnected. Just keep hold for a moment. Yes, doctor disconnected due to some network issue. So she will be joining shortly. So sorry, unfortunately, after completion of the program, doctor is not able to join due to some network congestion issue. So thank you very much. I want to convey my sincere thanks to Madam, Dr. Arti Shukla Madam, for her valuable time and for such a nice discussion on this emerging topic, that is recurrent pregnancy loss. With this short note, we want to conclude this session for today's, and have a good day to all the participants. Thank you very much. Thank you all.